Okay, so we are starting the second part of our endometrial tumors section, and it's a very small part. We have only the non-estrogen dependent tumors remaining. So let's get started. So as you see, right there, that in the Kurt notes they are calling this as other endometrial carcinomas or other endometrial tumors. However, I need you to know that these are not due to unopposed estrogen, because in one of the Q banks they ask about which of the following tumors is not estrogen dependent. So you need to know that all the subsequent entities, including serous carcinoma, clear cell carcinoma, these kind of things, they are not really dependent on estrogen. What's really dependent on estrogen is the endometrioid adenocarcinoma that we covered in the previous lecture. So there we go. We have the serous carcinoma. In the serous carcinoma, you have really atypical cells. The cells look really bad. They look really malignant. They look very atypical. High degree of nuclear pleomorphism, high NC ratio, to the point that you have, they call it large atypical nuclei. The nucleus is occupying most of the cell. And see, he's saying scant cytoplasm. The cytoplasm is not scant, but the nucleus is very big, very huge. This is because of how the nucleus is getting so big. So it's very large, very atypical nucleus with high degree of nuclear pleomorphism and a high degree of prominent nucleoli, as you see here. And the nucleus is occupying nearly the entire cell, to the point that you're saying that you're having a little bit of cytoplasm or scant cytoplasm. A lot of mitosis, numerous mitosis. However, I always rely on this as the key in order to train your eye on how the serous carcinoma look like. This scalloped luminal border. See, look at this lumen. See how the lumen is not very irregular. It's extremely, extremely irregular, as you see right there. That's what they mean by scalloped, irregular luminal border. Unlike what you see in the endometrioid adenocarcinoma, in which the cells are sharing a common lumen. No, here the lumen is very irregular, very scalloped. And you see some cells are ripping off. It's as if you're ripping off cells and they're falling inside the lumen. See, like this one. It's very classic. When you train your eye, you'll be able to easily identify that this is highly likely to be serous. However, if you are in doubt, sometimes, well, I'm not sure whether this is endometrioid adenocarcinoma high grade or is it serous carcinoma. So you do P16 and P53. P16 and P53 are extremely, extremely, extremely important to differentiate the serous carcinoma from the endometrioid adenocarcinoma. So as you see here, serous carcinoma are P53 mutant, which is either diffuse or null. And I showed you a picture of P53 in the previous lecture, so you'll be able to identify when the P53 is mutant, what are the mutant patterns, and what's the wild type pattern. So P53 here is mutant, and P16 is block positive. Dense positivity, block positive in all the cells. So it lights up really bad. It lights up very much with adding P16. And you can confirm as well by ERPR. ERPR on the other side is positive in endometrioid. So ERPR positive in endometrioid, P53 and P16, P53 is mutant and P16 is positive in serous carcinoma. That's the way to differentiate if you are in doubt in terms of morphology. However, sometimes the histology speaks. The H&E speaks up, and it tells you that you are dealing with a serous carcinoma, definitely. It can be solid, it can be glandular. Here, there is no grading. You cannot say a FIGO grade. because it's honestly, this is usually very solid, extremely. You see, it's often infiltrate in gapping to slit-like glands, and it looks really bad. It's in old-aged women, and sometimes it arises on a surface of a polyp, on top of a polyp. This one, just read, it's called serous endometrial intraepithelial carcinoma, which is serous carcinoma, which is very superficial. It's not invading the myometrium or not invading the deep layers of the uterus. That's why it's a non-invasive precursor to serous carcinoma. It's usually confined to the surface epithelium or confined to a surface of a polyp, and it's not going deep or not invading inside the wall or in the layers or in the wall of the uterus. Okay? Okay. Serous carcinoma is one of the aggressive tumors. And it looks aggressive histologically, and it's aggressive also in terms of prognosis. It has high ability to disseminate, and it has high ability to send peritoneal seeds or peritoneal seedings in the peritoneum, especially the serous carcinomas of the ovary, as we'll talk later. Very aggressive, extremely bad. This one too. See, to the point that this serous endometrial intraepithelial carcinoma, they call it SEIC or SEIC. This SEIC, although it's confined to the epithelium, it's there on the surface of the polyp. It's not invading in the wall of the uterus, but they can still undergo transtubal metastasis to the pelvis. This tells you how much the serous carcinoma love to metastasize to the pelvis and to go to the pelvic peritoneum. That's very important. Prognosis is dependent on the stage, whether she's lucky enough she got the cancer early or it's too late. That's the serous carcinoma. Remember P16, P53, remember the scalloped lumen, and remember the cells ripping off. High-grade nuclei. That's what you need to remember. It loves peritoneal metastasis. Next is clear cell carcinoma. And the same IHC. You remember that? These two IHCs, I believe you remember these. Now we repeatedly said clear cell carcinoma everywhere. Like we had clear cell carcinoma of the vulva, I believe, or the cervix, and then we have having clear cell carcinoma of the endometrium, and we'll have clear cell carcinoma in the ovary. We'll have clear cell carcinoma everywhere. It has the exact same positive IHC that you need to memorize, which is napsin A and HNF1 beta. This is very rare in the endometrium, extremely rare diagnosis. However, as you see here, you see the classic clear cells and the high-grade nuclei or malignant nuclei with prominent nuclear atypia, and the cells with clear cytoplasm. And you also sometimes see the hyaline globules. Here are the hyaline things, or the hyaline globules within extracellularly, maybe in the lumen or something. There is not many mitosis, however, it happened in postmenopausal women, and it has a relatively poor prognosis. Classic classic two IHCs, which are positive, are napsin A and HNF1 beta. Just remember these. That's clear cell carcinoma. Very easy. Mucinous carcinoma also. This looks like the mucinous carcinoma elsewhere. In other places, sometimes they change the name. Like they change it from mucinous carcinoma to colloid carcinoma sometimes. However, it's all the same thing, like malignant cells floating in pools of mucin. And the percentage of mucin differs from one organ to another. Like sometimes you see some organs, they say more than 30% mucin. Some organs you see more than 50% mucin, like here. Right here you see, so now it's just a pattern of endometrioid adenocarcinoma in which more than 50% of the neoplasm is floating in mucin. It has a frequent KRAS mutation. You can still grade this using the FIGO grading because it's a subtype of endometrioid adenocarcinoma. it has a relatively good prognosis, and make sure that it's not endocervical. Make sure that it's not endocervical, it's just making its way up to the endometrium. So see that he didn't include a picture for mucinous, so I tried to get a good picture for that. Here is the malignant endometrial glands, and here is the mucin pools, or the pools of mucin, making up more than 50% of the tumor, with some cells floating in the mucin pools, as you see right there. It's good prognosis, and you have to make sure that these are not endocervical glands, and this mucin is not coming from the endocervix. However, it's very easy to differentiate. Sometimes you have mixed carcinoma, which is a mix between serous, mucinous, and clear cell or whatsoever. So we have serous carcinoma, clear cell carcinoma, mucinous carcinoma, and mixed carcinoma. All right. This is undifferentiated carcinoma. What I mean by undifferentiated carcinoma is, I don't know. All what I see is just discohesive cells filling up everywhere in the field under the microscope. And all these discohesive cells look very ugly. See, uniform, monotonous, discohesive cells with condensed chromatin, and it's not taking the shape of any pattern of an endometrial carcinoma that I know or I identify. Like, I can't say this is endometrioid. Also, I cannot say this is serous. No clear cells. I can't say this is clear cell. Not mucinous. There's no mucin pools. So there is no overt differentiation. It's usually very, very high grade, to the point that it lost completely its differentiation. That's an undifferentiated carcinoma. There is no gland formation. It looks like, if I give you this slide in cytology anywhere, and you see this cohesive blue cells which look malignant, what do you suspect?
Lymphoma, melanoma, polydifferentiated carcinoma.
Yes, lymphoma mainly, but you said melanoma, that's correct. But lymphoma mainly, like blue cells, discohesive, filling up the area in the cytology, this lymphoma. And see, that's what he is saying. It resembles lymphoma a little bit. However, it's actually endometrial. And there's some actually lymphocytes in the field, like tumor infiltrating lymphocytes, like this one possibly. So it has some kind of tumor infiltrating lymphocytes, and it's usually forming a very huge mass, large mass, filling the uterine cavity very bad. Sometimes they say that this could be a start of sarcomatoid differentiation, which indicate poor prognosis, of course, and indicates aggressiveness on top of a tumor which was already there, like an endometrioid or a serous, but then it undergone this sarcomatoid differentiation, and it looked like this. It usually show loss of INI1, which is SMARC-B. SMARC-B is very, very, very common marker and very, very common mutation or molecular mutation in these kind of sarcomatoid appearing discohesive blue cell tumors. If you see like a tumor which is sarcoma-like, the cells are discohesive, they doesn't form any pattern, and they look very bad, and they are filling up the whole microscopic area or the whole microscopic field. But usually it's associated with loss of INI1 or SMARC-B1 or SMARC-A or SMARC-B. It's of course very, very aggressive. I never saw that in a question, honestly, in the Q banks for the boards. There you go. That's dedifferentiated endometrial carcinoma. Dedifferentiated endometrial carcinoma means that you are lucky enough that you see the primary endometrial cancer there, like endometrioid adenocarcinoma, and then you see an abrupt, sudden dedifferentiation into a dedifferentiated carcinoma. See, low grade. So see two distinct components you see under the microscope. Number one, is a low-grade endometrioid adenocarcinoma FIGO 1 or FIGO 2. And then you see another area which is high-grade undifferentiated carcinoma like the one you see above. And that's why I'm saying that they believe that this one was actually like this, but it's too late. The patient was discovered very late to the point that there is no low-grade FIGO 1 or FIGO 2 component remaining. It's just the undifferentiated component. That's what you see under the microscope. And see, he's saying the undifferentiated component has the same mutation as WF, SNF, which are the SMARC-A and SMARC-B mutation. And the low-grade endometrioid carcinoma will have its own distinct immunohistochemical pattern, which is ER positive, PR positive, P53 wild type, P16 negative. The same thing as you see in the endometrioid adenocarcinoma we talked about before. Carcinosarcoma is common. You need to know that. They ask in one of the Q banks about the history. They give you a microscopic picture which has the two components, the carcino component and the sarcoma component, carcinosarcoma, carcinosarcoma. And then they ask which one of the following history applies to the patient having this condition. And then they give in one of the choices postmenopausal women with a mass, with a pelvic mass prolapsing out from the cervix. This is usually the classic. These kind of tumors are very, very aggressive. They get very huge to the point that they fill the endometrial cavity, and then they might go down and prolapse outside the cervix and prolapse outside the vagina. That's the carcinosarcoma. Anybody know the other name for the carcinosarcoma? They sometimes call it what?
MMT something,
Yes,
mixed
triple
Mullerian
MT.
something. Yeah,
triple MT. Mixed Mullerian, mixed something Mullerian tumor. It's called triple MT. Triple MT or carcinosarcoma is the same thing. However, here you have a sarcoma component or a mesenchymal component. Here it is ugly looking sarcoma. Ugly looking sarcoma, extremely pleomorphic. It's like what you see in any ugly looking sarcoma. And you have a carcinoma component. However, the carcinoma component here is high grade. Please remember that. You need to see high grade carcinoma component. See that what makes a difference between carcinosarcoma and dedifferentiated endometrial carcinoma. Dedifferentiated endometrial carcinoma, you have a low grade epithelial or low grade endometrioid, FIGO 1 or FIGO 2, and then a high grade dedifferentiated component. However, here you have sarcoma component and high grade carcinoma or epithelial component. They believe that carcinosarcoma is actually a mixed tumor arising from two separate lines. Like the sarcoma is having its own origin and the epithelium is having its own origin. However, in the dedifferentiated endometrial carcinoma, they believe that it was endometrioid, and then this what led to dedifferentiation, and this what undergo dedifferentiation and made the dedifferentiated part. You got it? So that's how it looks like. See, high grade epithelial component plus high grade sarcomatous component, which is mesenchymal, sarcomatous. So high grade carcinoma, epithelial, and high grade sarcoma. So this is postmenopausal women. The mass is big enough, it prolapses out of the cervix in nearly half of the cases. And the carcinoma component being high grade, it's usually serous. It's often serous. However, it might be also endometrioid, but for it to be endometrioid, it should be high grade endometrioid, which is FIGO 4, like very solid. See, he's saying that sarcoma is often high grade sarcoma. It's high grade, just non-specific sarcoma, just whatever you see in any high grade sarcoma tumor, you will see in this element. And you might see some heterologous elements, like you might see some areas of cartilage, some areas looking like chondrosarc, some areas look like osteosarc. But the most common is rhabdoid. You might see some rhabdoid areas in the sarcoma component, like these rhabdoid cells with glassy cytoplasm, which look like rhabdomyosarcoma. It has p53 mutation, and of course this has a very poor prognosis. Frequently metastasize to the lymph nodes and to the pelvis, and frequently reoccur after surgical removal. Yeah, it's very bad. That's rhabdomyoblastic differentiation. See these rhabdoid cells, striated cells, has these cytoplasmic red stria, which look like striated muscle. That's the rhabdoid cells, rhabdomyoblastic differentiation, and this usually there in the sarcoma component. So we have high-grade epithelium, high-grade sarcoma, TP53 mutation or P53 mutation, postmenopausal women, big, huge mass, prolapse out of the uterus. Poor prognosis. This one he added actually in the new version of the notes. It was not there. It's mesonephric-like adenocarcinoma. I don't really know much about it. I didn't even encounter this in the Q banks. So I don't know, maybe this is a new entity. However, I've never faced it even in the questions. However, he's saying that this is adenocarcinoma with mesonephric-like differentiation, which look like mesonephric remnants. Remember, we had the same thing when we were talking about the cervix. We talked about some mesonephric duct remnants. And I believe we mentioned that from these mesonephric duct remnants, there might be mesonephric carcinoma or mesonephric adenocarcinoma. It retains the mesonephric IHC, which are very important, the TTF1 and GATA3. TTF1, GATA3, very important. These are positive because it belongs to the mesonephric duct, which is like a kidney. PAX8, GATA3, it's like the the urinary system. PAX8, GATA3, and it has also TTF1 positivity. They seem to be aggressive, so they don't know. It looks like that this is a new entity. He's also talking about gastrointestinal type endometrial adenocarcinoma, and he said it's very rare. Also, this is added as well. He said you might see goblet cells. I don't know. I believe these entities are brand new. Squamous cell carcinoma, I was lucky enough to see one case. And the thing is, when we saw this case, me and that, oh, I see a question here, sorry. Dina is asking how to differentiate from metastasis. Which one you mean? You mean the triplet?
I was talking about the undifferentiated, the first one, because you said it lose all the markers, like the PAX8.
This one?
And the AR.
You mean this one?
Yes, this one.
Undifferentiated one? Well, you mean differentiated from something sent metastasis to the uterus at first?
Yeah, like I mean,
endometrium is a very rare site of metastasis, by the way.
okay.
It's not like the brain or the lung or the liver. You'd rarely have a tumor which send metastasis to the endometrium. However, differentiating this from undifferentiated carcinoma, what do you mean that undifferentiated carcinoma could be coming from somewhere else? Because it's undifferentiated, I don't know. I agree. However, when you examine the specimen grossly, the mass is entirely coming from the endometrium. So if it's metastasis, it would be deposits, like metastatic deposits. However, this is like occupying the whole endometrium. It looks as if this is the primary. Looks like the primary is from here. You got it?
Yes, thank you so much.
Yeah. So I was lucky enough to get a case of squamous cell carcinoma of the endometrium. It was like so uncommon, you know. It's uncommon that you have. Well, we had like a case, okay, malignant. We know that this is malignant uterus coming, and then the patient for some reason didn't have an in-house biopsy. I remember this case. So he didn't have in-house biopsy, so we don't know what's the previous diagnosis on biopsy. Okay, let's do it. And then, well, I grossed and everything, and then I submitted the sections from the mass, blah, blah, blah. And then when we looked under the microscope, all we see is malignant squamous cells. So can I ask anyone like to jump in and tell me what would jump in your mind when you see that under the microscope? When you see like malignant squamous cells,
Carcinosarcoma.
you say carcinosarcoma. Well, carcinosarcoma, it has malignant epithelial component, correct? But the malignant epithelial component are usually serous or endometrioid, honestly. It's not squamous cell carcinoma. But what else do you think it might jump in your mind when you see squamous cell carcinoma in a slide coming from the endometrium?
There are two things. Like first, I would think maybe it's a floater or something.
Floater.
If it's
Okay.
just like a small piece in the whole slide, but if I see
No, the whole slide was actually occupied by malignant squamous cells forming nests, which looked like a classic squamous cell carcinoma. Well, the attending suspected that this is coming from the cervix. You got it? You got it. So it's like, oh my God, it might be squamous cell carcinoma of the cervix coming up, or we should also rule out that this is actually squamous metaplasia on top of endometrioid, and we're missing the endometrioid part. So she told me that time to submit more sections, more representatives from the tumor. We need to submit more representatives from the tumor. Maybe we're missing the tumor, and this is just squamous metaplasia. However, I'm sure I'm seeing malignant squamous cells. However, before calling it squamous cell carcinoma, we need to back up a little bit. So I submitted more and more sections, and all what you see is malignant squamous cells. So unfortunately, the attending told me, so unfortunately, we have to deliver this bad news to the patient that this is endometrial carcinoma. See, with exclusive squamous differentiation. And this is actually, she said, this is very poor prognosis. It's very bad prognosis when you see it in the endometrium. However, you must first exclude, as you see here, you must exclude endometrioid adenocarcinoma with squamous morioles or squamous metaplasia or cervical squamous cell carcinoma making its way up to the endometrium. That's the two key things that you need to rule out. You need to make sure that you are dealing with an endometrial tumor, not dealing with a cervical tumor, and examine the cervix carefully and take the proper sections and take more and more representatives to make sure that there is no endometrioid adenocarcinoma anywhere. That's just for the clinical practice. It will not come in the boards. What come in the boards is the classics, like the endometrioid adenocarcinoma, the clear cell, although it's rare, but they love it because they know the characteristic immunos, the serous. So make sure you know these rather than just like these ones you might encounter in your practice and maybe once or twice in your whole career. Here is some tables to help you out. From this table, I will tell you the keys. You need to memorize that endometrioid adenocarcinoma is ER/PR positive always. Serous carcinoma is usually ER/PR negative. However, you may encounter some cases with ER and PR positivity in serous. However, P53, P16, very important. P53 is wild type in endometrioid and is mutant in serous. It's abnormal in serous, either null or strongly positive. P16 is negative in endometrioid and it's block positive in serous. This is very important. And then napsin A and HNF1 beta are the two key immunos which are positive in clear cell carcinoma of the cervix. Clear cell carcinoma, it doesn't matter of where. It's actually even there in the, so clear cell carcinoma of the endometrium. However, it's negative in the others. However, serous might show napsin A and HNF1 beta positivity, but it's usually negative. So this is just an endometrial polyp classification, like how each one looks like in terms of how the epithelium look like and how the stroma look like. I didn't find this table helpful, honestly. And this is the architecture. like an architecture-based approach. Like when you see clear cells, what your mind have to think about when it comes to benign and when it comes to malignant. Like when it comes to benign, it's area stella reaction. And when it comes to malignant, you might think of clear cell carcinoma or endometrioid sometimes appear very clear. When you see papillary architecture, what you are suspecting is like surface papillary syncytial metaplasia. Oh, we talked about this in the benign endometrium, but it's not very important. However, when you see papillary, you're either micropapillary with cells ripping off as if they are papillae, that's serous carcinoma, or endometrioid adenocarcinoma viloglandular pattern. When you see mucinous, I would suspect mucinous metaplasia if benign, and I would suspect mucinous carcinoma of the endometrium if it's malignant. I'm talking about the boards. And he's saying that what's the squamous, what's solid. Not really important. These last 2 pages are just for collection, like some collections to try to stimulate your mind. So who want to start?
I can take this one.
Okay.
So what I see a high grade, it looks like slit-like spaces between this, looks like papillary maybe. I'm thinking with this high grade serous carcinoma.
Yes. Well, you're thinking of high-grade serous because you see like the lumen is not very regular and it looks like papillary, and I always say papilloid. It's like pseudo-papillary, but it's not very papillary or not that much papillary. However, you see also high-grade cells. The cells are very high-grade, so you are suspecting in terms of diagnosis
Serous
serous
carcinoma.
carcinoma. If this is coming from the endometrium, so it's serous
Yes.
carcinoma of the endometrium. Okay.
IHC
Yeah,
is
but you need to do IHC to prove because it might be like papillary pattern of endometrioid. Because if we go back, I will show you something. Let me show you this since we have time, because today we are very relaxed. Let me show you this. See? Sometimes it has papillary architecture, the endometrioid. So just in case, well, I'm suspecting serous. I'm favoring serous. However, to rule out papillary pattern of endometrioid adenocarcinoma, which IHC combo you will order?
the P53, sorry, P16 and yes, P53.
Yeah, P53, P16. And what are the 2 IHCs you will order for endometrioid?
ERPR.
ERPR. So you need to order ERPR, P16, P53. If this turned out to be serous, can you tell me most likely the ER and PR would be?
Negative.
Negative. And the P53 would be?
The null or the...
Yeah, it's mutant.
The mutant, okay.
Mutant pattern. And then P16 would be?
Block positive.
Yeah, strongly positive or block positive. Good job. The prognosis here is good or bad?
Very bad.
Yeah, the prognosis is bad. Okay, good job. So that's high-grade serous or serous carcinoma of the endometrium. Who want to take the second one? Yes,
I can take it, I think.
Yes.
I see like a nest of clear cells.
Yes, clear cells.
Okay,
So
clear cell with some pleomorphic cells, prominent nucleoli, and I think this is, I don't know, prominent. This is like calcification where those 2 arrows are pointing at. I'm not
maybe calcification might be the hyaline globules. I don't know.
Oh, hyaline globe. Yeah, I don't know.
Possibly,
like,
but I don't know.
Okay.
So the
So
diagnosis
this
would be
clear cell carcinoma.
Clear cell carcinoma. And the IHC?
Napsin and HNF beta 1 or 1 beta.
Yeah, and then HNF 1 beta. All right. Good job. All right. Next case. Who want to take over? We have who remaining? We have Mariam, Abdurrahman, and Aliya. Who want to go? Okay, so if I have to pick up one, yeah, okay, Mariam. Okay, I was planning to pick up my friend. I will pick up Abdurrahman because he's like my
Okay, okay, yeah.
but since you said I will go, so it's okay. But Abdurrahman will take the next one.
Okay.
So what do you think of this lesion? This lesion was it came to you from endometrial biopsy. What do you think?
Yeah, it is a polypoid lesion. I can see glands, kind of increasing glands, that some of them are kind of cystic,
Or dilated. Yeah,
dilated glands. But in this power, I can't see any ATP, so maybe I will call this.
What's the arrow pointing at? This arrow. What is it pointing at?
It's a fibrovascular.
Yeah, they're pointing at
vessel.
the blood vessels. The blood vessel. The blood. So you what are you calling this first? Let's see what you are planning to call it.
I will call this polyp.
Yeah, endometrial polyp.
Yeah.
Endometrial polyp. So see, I'm asking you the next question. Mention the two golden histological features for the diagnosis. You said already one, which is cystically dilated gland.
Yeah, and cystically dilated gland and the vessel, I think. Another vessel.
Which is thick
wall.
Please remember thick-walled vessels. Yeah. Maybe it's not obvious here, but if you go high power, you would see the thick-walled vessel. But just this is because we are looking at the low power. Okay.
Yes.
All right. And good job from your end that you said, well, highly likely this is not like showing atypical cells, because you are suspecting that you might, when you go to high power, you might see endometrioid adenocarcinoma on top of polyp, or serous carcinoma on top of polyp. All the cancers might happen on top of endometrial polyp. Okay. All right. Good. Abdurrahman.
Yes, I'm here.
Yeah, my friend. So polypoid lesion here. Number 8.
Yeah, polypoid lesion. Okay. Is it a dedifferentiated one?
No, I say polypoid. Remember, it's telling you polypoid. So what do you see here? We see some glands.
Well, I see glands and stroma.
Yes. The key thing is abundant stroma.
Yep.
So you have abundant stroma in between. And if I erase the glands from this field and you see only this kind of stroma, what would you think it could be? This whorly appearance of stroma. And this like spindle whorly appearance that's making whorls. What do you think? Yes. Leiomyoma. So if I remove the glands from the field, you'd say it's a leiomyoma. So now I added the glands. So what should it be? And it's a polypoid lesion.
It's the carcinosarcoma.
No, it's the APA. What's the APA? You remember I said this is very boardable. So remember this. Here it is. Here it is. The atypical polypoid adenomyoma.
Oh, that's the
APA. Yeah. See this picture? See this picture? Glands with abundant whorly appearance stroma with like smooth muscle. See, he's saying fibromuscular stroma.
Yeah. There's the glands and the stroma in the muscle.
So remember this. Put this in your mind. And they always say that this is a polypoid lesion in the board. They say it's a polypoid lesion, and then they give you this picture. Oh, when I see it, I see these like relatively benign looking glands and a background leiomyoma like stroma. I say, oh, this is APA, the atypical polypoid adenomyoma. Okay?
Okay.
So can anybody enumerate for me? We have Alia remaining. Can you enumerate? But Alia, did you attend yesterday? I don't remember. I don't think so.
Yeah, I attended, but
you did? Oh, okay, but can you try to can you try to memorize the molecular subtypes of endometrioid or endometrial adenocarcinoma? So let's forget about this copy number high. I would never enumerate them. Even me, I wouldn't have the capability of enumerating them. But can you tell me which targets we target in the molecular to see?
I remember first we go with poly-G.
Yes, poly-E, which is polymerase epsilon. Okay. And what else? MMR.
MMR, yes, MMR.
Yes, mismatch repair, very important. We do all the MMR and the mismatch repair proteins. We do them routinely in all endometrioid to make sure whether like MLH1, MSH2, PMS, these things, we do them in all endometrioid. And what else? The P53.
P53.
The
Yes.
P53 to rule out the serous carcinoma-like endometrioid. You remember this? Let's go back and memorize this together. It's in this page. I hate this kind of complex name. Ultra-mutated, poly-mutated subtype, hyper-mutated, microsatellite unstable subtype. No, I just want you to remember that we do poly-E first, and then after poly-E we do MMR, and then if MMR is good and poly-E is good, we have to do P53 to see whether it's wild type. Then it becomes no specific molecular profile. If it's P53 mutated, it's called serous-like endometrioid adenocarcinoma, which was really bad, if you remember. The serous-like subtype has a very poor prognosis. It usually presents in an advanced stage, right? Okay. So we are good. We are good. We are done with endometrium. We did the benign endometrium. We finished even endometrial tumors. Next in line would be the ovary, right? We have only the ovary remaining. Am I correct? Just let's go back to, yeah, we did vulva, we did cervix, we did benign.
Fallopian tubes.
We did endometrial tumors. Yeah, we have the adenexa, ovary and fallopian tubes. They are both in one note, in Kurt notes. But we have also the mesenchymal tumors of the uterus. However, the only thing that is asking the boards in these mesenchymal tumors are the leiomyoma and leiomyosarc. That's the only thing that they ask. But sometimes they have this stromal tumors. You might get to a question every now. But let's finish ovary first. I believe we should go over the ovary first because it's more important. We'll go over the ovary and fallopian tubes, and then we will finalize with the mesenchymal tumors. Like we'll do it very fast or real quick. And then we will be done with the GYN, and we will have the voting on for the next subspecialty that you need to cover, and we will go from there. All right. So I think we would be able to meet tomorrow. However, also please wait for a heads up from me. I'm sorry I gave you a very late heads up today, but I'm very happy that you are always there on board. Like, you know, we are waiting. When once I post, you give me a react, and then we are ready, and then we can go right away. So I love this spirit. Thank you very much. But I will try as much as I can to give you an early heads up in case you have any arrangement. You don't want to end up staying and then I tell in the last moment that I'm not giving the lecture. Okay. Thank you very much. I appreciate it. And I hope that you enjoy the rest of your day. Thank you very much.
Thank you.
Thank you so much.
Thank you.